Good afternoon. I don't want to stand between you and the lunch. At the outset, I want to thank Vijay Bada for this opportunity to share. But let me give a disclaimer. He said that I should talk only about the indications and difficulties. And he also said that I should not beat around the bush, straight away get onto the topic and finish it on time. So without much of an ado, what I can tell you is that my topic has already been covered by the previous speaker. In fact, he has shown in all these slides as well. So for the want of the younger surgeons, because Subbu sir also has mentioned about the training and the importance of the next generation to be trained on esophagectomies. So I want to keep it a little bit at a low intensity and take you through some basics of indications and difficulties in esophago-gastrectomy. So when the topic was given to me, I was a little bit confused whether every esophagectomy is actually esophago-gastrectomy in that sense. So it's partial or semi. So in that sense, there's no clear-cut definition as such. But my focus will be more on Ivor-Lewis because that's what we assume to be esophago-gastrectomy. So this surgery, especially for younger generation, is not a simple surgery. You need to understand the complex anatomy. And the curative potential is very much there nowadays with the advent of Neoadjuvant. We've heard a lot about FLOT and how the FLOT has, in a way, overtaken the cross protocol. So we need a good volume expertise required to perform this. So the indication specifically, we have already seen just now a few minutes ago, lower esophagus, whether it is squamous or even adenocarcinoma, and of course Sievert 1 and 2. I would not go for 3. Benign indications also we do have. That could be, the indications mentioned there in the slide. For want of time, I would skip that again. So what is the choice of surgical procedure for, how do you decide? Depends upon the location, depends upon the extent of lymphadenectomy that you are planning based on the histology and also the location, and of course the reconstructive technique with which you are very comfortable, because all these options we have discussed extensively. None of them is superior than the other. It all depends upon the comfort and your experience and the institutional practice that you have. So the surgical approaches that we have for esophageal-gastrectomy includes right from open to minimal invasive. We have seen all of that right now in the previous video, right from VATS laparoscopy to robotic esophago-gastrectomy. So what is important is that the minimal invasive surgery has given less morbidity, better precision, and better outcomes to our patients. So the surgical approaches, the basics, if you look back, we have 3 of them. We have covered them, but just for repetition's sake as well, I will mention. So right from Ivor-Lewis, which is abdominal plus thoracic approach with intrathoracic anastomosis, whereas the standard McKeown 3-field esophagectomy, wherein you do the cervical anastomosis, you have the lymphadenectomy of all the thoracic, abdominal and the cervical part. So the Worringer, again, a lot of discussion, so I won't talk much about it, but definitely in some select cases, there is a role for transhiatal esophageectomy as well. So this is just a pictorial representation of these 3 procedures, right? So what is important is that the upper thoracic, definitely we would choose McKeown procedure. For mid and lower, mid as well, I will go for McKeown, but Ivor-Lewis is meant especially for lower and Sievert 1 and 2. So what you see here is that the other approaches surgically which were done in the past when I was a student was right thoracotomy and diaphragmatic incision to do the abdominal part. Of course, in the good old days when I was a resident in surgery, we used to do left thoracoabdominal incision, which is no longer practiced. So the transhiatal approach, again, much has been discussed, so I would skip that. We have all gone through since morning we have seen about the classification of the Sievert and how you would label them as 1, 2 and 3. So I think there is clarity with respect to the procedure that we do based upon the anatomy or the location of the tumor. So just to give an overview of which procedure has got what kind of an advantage. I think for McKeown, we know cervical anastomosis, whereas Ivor-Lewis is intrathoracic. For transhiatal, of course, we do the cervical anastomosis. So as already been discussed by Dr. Senthil, the anastomotic leak is higher in the McKeown, but it's easily manageable. So whereas in the Ivor-Lewis as well, it can be catastrophic, but the leak rates are less. So again, transhiatal, higher rates because of cervical anastomosis. So if you look at the injury for the recurrent laryngeal nerve, definitely 3-field has a higher risk, but again, with minimal invasive surgery, even that has come down. So the recovery is much more longer for McKeown compared to Ivor-Lewis and transhiatal. So pulmonary risk again is moderate for McKeown compared to Ivor-Lewis.